SmithKline & French Laboratories is pleased to bring you the first of a new audio cassette series, Update on Borderline and Narcissistic Disorders, highlights of the 8th Annual Psychiatry Conference of the Menninger Foundation. Dr. Michael Stone, Professor of Clinical Psychiatry at New York Hospital Cornell Medical Center, opens the program with an update on diagnostic and treatment issues in borderline disorders. First, here's a brief message from SK and FCO.
Your patients, their journey from fear, slow passage from a dark world of chaos to the ordered vision of reality. Your patient's progress is a tribute to your talent, your painstaking skill, and the benefit of modern psychotherapy.
Today, more than ever before, we feel it's important to remind you that when you wish to ensure the continuity of treatment so valuable to your special patients, it's up to you, the prescribing physician, to demand that the drug you prescribe is the drug they receive. To protect your patients, protect the integrity of your prescription. Always write Stelazine DAW, do not substitute, or use the format required by your state.
For almost 30 years, psychiatrists have relied on Stelazine in the familiar True Blue tablets to maintain their chronic schizophrenic patients through effective control of psychotic target symptoms.
And since, as you know, Stelazine apparently activates withdrawn, apathetic, or detached patients, you have a greater opportunity to reach your patient with other forms of therapy. Your patient suffers less, responds faster.
In addition, Stelazine offers these treatment benefits. Stelazine seldom causes excessive sedation. Stelazine demonstrates a low risk of anticholinergic effects and hypotension. Stelazine offers convenient, economical BID dosage.
And while Stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics, these symptoms, when encountered, are generally readily controlled.
We urge you to prescribe prompt, non-addictive, activating Stelazine for your chronic schizophrenic patients.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions such as pseudoparkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with Stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing Stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions.
Be sure you're the doctor. Always write Stelazine DAW, dispense as written, or do not substitute. Or use the formula required by your state. Protect your patients. Exercise your right.
Now, here is Dr. Stone with an update on borderline disorders, diagnostic and treatment issues.
The situation with diagnosis in borderlines was very much in a kind of a chaotic tumble for a number of years until DSM-3 came along and first of all accepted the term into the standard nomenclature, which it had not been before, and then gave it some fairly precise boundaries, which even though they have a lot of simplistic qualities and a rather cookbook, nevertheless create a common language so that clinicians and researchers throughout the country and throughout much of the Western world really have begun to define borderline in pretty much the same way. The definitions for borderline were rather fuzzy and vague within the psychoanalytic community, but they mostly picked up on such qualities as kind of ego weakness, fragility, a tendency to depression and paranoid feelings, a tendency to rage outbursts, to being impulsive. In the very late 70s, after Gunderson's articles in the American Journal of Psychiatry became more widely known, and Kernberg's work became more widely known also, Dr. Spitzer at Psychiatric Institute, where I was at the time working as Dr. Kernberg's associate, decided he would try to take what was essential from competing and somewhat differently derived definitions to see if he couldn't get it into computerized shape, really tight definition. As it turned out, the average borderline patient was neither purely schizotypal nor purely unstable, but a mixture. That led to a suggestion on my part that the word borderline, in order to remain closer to the tradition, especially in the analytic field where the term, after all, got popularized, that both items, pure schizotypals and pure unstables, be included under one heading called borderline. And then if it so happened that the person had mostly the schizotypal items, identity disturbance, unstable relations, labile mood, inappropriate and intense anger, impulsivity, self-damaging acts, boredom or chronic emptiness, and an intolerance of being alone, magical thinking, delusions, paranoid, suspicious thinking, poor rapport with the interviewer, the tendency to withdraw, to be excessively anxious in social settings with only one or two of the schizotypal items, you said that's a borderline unstable type. And if they had a mixture, you said this is a mixed borderline. That way the word borderline would be there all the time. That is an idea that was not appealing to Spitzer, even though it has some appeal, to others. It may crop up in DSM-4, but it is certainly not in DSM-3. Nevertheless, I think that approach is more useful because it provides coverage and yet a better measure of specificity and is very much in line with the last 40, 50 years of tradition, which I think is important in order that the meanings not get too far away from their origins. In the group of patients with which I'm most familiar, which are the 550 patients who were admitted for long-term intensive psychoanalytic-oriented psychotherapy at Psychiatry Institute between 1963 and 1976, what I call, in order to be in line with Min Swang's Iowa 500, I call them the PI 500. The PI 500 included 300 borderlines. I have almost completed diagnosing them with respect to Gunderson-Kernberg DSM subtypes, so I, at this point, have a pretty good handle on the proportions, although I couldn't give you exact numbers. But it turns out that about 80% of the Kernberg borderlines, which was how we diagnosed them originally, are DSM positive. The ones who are not fall into certain subcategories. For instance, there are patients who were called borderline, and certainly still would be by structural or Kernberg criteria, who were agoraphobic, but who lacked anything in the way of inordinate rage, were not particularly impulsive. If anything, they were stay-at-homes, who led very sheltered and marginal existences, and they would not be picked up as being borderline by DSM. They also don't have, all of them, identity disturbance particularly, and certainly not unstable relations. If anything, they have very few relations with anybody at all. But they obviously have intolerance of being alone. So that's one group. Some of the agoraphobes, on the other hand, happen to have enough items from DSM that they are borderline in both senses at once. Then you have some people with an identity disturbance who are not impulsive, not rageful, and would clearly be picked up by Kernberg, but are definitely not DSM-3. There are plenty of sociopaths who are glib more than turbulent and who do not show problems in being alone and are not particularly bored. They're often sensation-seeking, and many people who are sensation-prone are bored and are seeking sensation in order to fight the inner feeling of emptiness and boredom. But I can assure you that there are some other people, particularly certain rather glib sociopaths, wheeler-dealer types, who were not particularly bored, but who do crave a sensation, possibly because they were reared in atmospheres where that was the order of the day in their own families. They would be Kernberg positive, DSM negative. Then the Grinker type 4 borderline, the anaclitic depression. Some of those people really are on the verge of being unipolar depressives and would be if you followed them out. But at the point at which you see them, they have an identity disturbance and this depressed, moody quality, but lack the rage, impulsivity, and self-damaging acts that would make them DSM by contemporary standards. Then there's the whole world of alcoholics and other substance abuse people, many of whom, but not all, are impulsive in other areas besides the area of their oral craving, and not all of whom are prone to inordinate rage, although goodness knows many alcoholics are. So there again you have a group that Dr. Kernberg tends to include and that DSM and certainly Gunderson would exclude. So again, don't throw your brains away and rely on DSM for these kinds of things. The clinician has a brain that simultaneously measures frequency, amplitude of various manifestations, and can pick up who the really sick patients are, who the ones that are better integrated, and so on. And there are far more subtypes and combinations in our brains that trigger the response, this is a fragile patient, than is going to be easily picked up by the necessarily simplistic definitions in a diagnostic manual. It's important to know whether there is this streak of affective disorder or whether there isn't, and you then make another diagnosis that this is a borderline with major affective disorder as defined in DSM, or it's one that isn't. The kinds of courses and the kinds of treatment are going to be affected by what you put down for that diagnosis, in the sense that the ones with major affective disorder may be the ones that go on to develop classical manic depression in the years to come, and then certainly require antidepressants or lithium or what have you, and the other ones may have less need for medication. They present a different distribution of subtypes and also have come by their illness in a somewhat different route. There are people who have no family history of serious affective disorder, no particular disorder other than in themselves, other than some sadness or depression, who have been abused as children, victims of incest, victims of child abuse, and so on, and who come by their unrealistic and rigid views of themselves and other people because of the traumata they suffered as youngsters, and therefore end up as borderlines by the time they're late adolescent or early adults, without having gotten that way through the genetic route, just as there are other patients who do seem to have rather impressive genetic loading for affective disorder, and then even in fairly normal family environment end up as the irritable, cranky, depressive, demanding, manipulative borderline patient that we recognize in the late teens and early 20s. Impulsivity is a key diagnostic item in all criterion sets for a borderline diagnosis, now as before, but one has the impression now that the nature and the extent of impulse discontrol is different now. The need for limit setting is even greater than before. Chaotic life, chronic drug abuse, and aggressive acts appear more pronounced in the borderline patients who come under our care in the past few years. Narcissistic traits, particularly entitlement and contemptuousness, seem more widespread even than in the previous cohorts of borderline patients. Those of us who spent our formative years in training and in early practice mastering a therapy for the impulsive but not so narcissistic, not so substance-abusing borderlines of the 50s or 60s find ourselves having to do what Detroit had to do after the gas crunch and the imported mini-cars: retool. I have no easy answer for this, but I know that the compliant therapist of the 80s, confronting the current wave of borderline patients, must begin to differentiate amongst them, sorting out those still amenable to an expressive technique from those in need of behavior modification, special anonymous groups for each variety of pathological craving, supportive techniques, pharmacotherapy, therapy in homogeneous groups, and so forth. We will also need to break down samples of borderline patients, especially samples selected by broad criteria, into more specific subgroups. Some of these will turn out to have an excellent prognosis, others a gloomy one. I have recently begun to categorize the 300 borderlines of the PI 500 into such groups. There were, for example, about 40 with concomitant antisocial personality, a similar number of anorexia-bulimia cases, and about 30 alcoholics. There were half a dozen agoraphobes and a dozen schizotypals. Some overlap, but not much, between these groups was present. A number of anorectics were living 10 to 20 years later at high levels of social function. Many had had extremely conflictual relationships with their own mothers and vowed never to have children of their own. Others could not accept consciously their disinclination to have children, and instead made one inappropriate relationship after another until at the age of 37, 38, they finally met Mr. Right, with whom they could now settle down into a comfortable because childless marriage. The alcoholic borderlines, like the antisocials, formed a bimodal outcome curve. Those who got into AA have done very well and really are often recovered now with global assessment scores in the 80s. Those who have not are mostly dead through suicide. The alcoholic borderlines have the highest suicide rate of any subgroup I've been able to construct. It is in excess of 30% at an average of 17 years of follow-up. There were a dozen pure-type schizotypal patients among the borderlines, along with a much larger number with mixed schizotypal unstable symptoms. The pure-type schizotypal seldom are seen in hospitals to begin with, are usually marginal loners who lead gray lives. Their global assessment scores are usually in the mid-50s, implying the persistence of certain symptoms in a rather disrupted life. They are working below capacity, not married, or involved in any close relationship. Behavior modification techniques would perhaps yield better results nowadays, though there are still some exceedingly fragile, often concomitantly manic depressive agoraphobes who resist everything that we have to offer. They, like the anorectic bulimics, are much less amenable to expressive therapy than Hilda Brooke and other enthusiasts were once inclined to suggest. One must be aware of the fact that the term borderline has been taken over by DSM and by the larger community of non-psychoanalytically trained psychiatrists, whereas in the 30s, 40s, and 50s, borderline was a territory at the edge of the psychoanalyst domain. This new definition emphasized impulsive and self-destructive activity even more than does the analytic psychostructural definitions that I mentioned earlier. All this contributes, I believe, to the change in apparent efficacy of expressive therapy with borderlines. The patients have changed in their typical personality profile over the decades. The therapist community has changed with respect to the profile of favorite modalities. And the definition has changed in the direction of a somewhat more ill, impulse-ridden patient population. Expressive therapy, as we re-examine its merits in 1986, without the benefit, admittedly, of a randomized study of borderlines, would seem to be appropriate within a narrower band of the borderline spectrum than was once speculated. The eating disorder patients were rarely good candidates for expressive therapy. 2 of the 6 agoraphobes did get well with expressive therapy, but as a group they are not highly likely to improve dramatically through insight-oriented treatment, so much as via behavior modification and vocational social rehabilitation. Most of our PI patients were hand-picked for probable amenability to expressive therapy, which meant in effect that most aggressive, as opposed to quietly delusional paranoids, were screened out, never entering the unit. Even so, there were 7 murderers. What violent aggressivity would be encountered in 500 unselected hospital patients in our own era, I leave to your imagination or experience. Certainly such patients are beyond the scope of expressive therapy. The patients I've just alluded to at all events comprise some 41% of the borderlines. Among the remainder, some 146 patients, the truly good candidates for expressive therapy, were to be found, but they do not number as many as this remainder. Some were simply not psychologically minded. A number were wholly unmotivated patients with inadequate personality. One I spoke with a couple days ago is, at 43, still living with his widowed mother, watching the telly, and making excuses for never working on account of minor physical ailments, just as he did while in the hospital 15 years ago. Another small group were highly motivated and well-equipped psychologically to make connections between past and present, only the past was too horrible. Cases of this sort involve frank incest with the father, chronic brutalization by a parent, or the suicide of both parents. A number of these borderlines kill themselves. A number who have survived live only marginal lives and could never endure the opening up of the old wounds, as would happen if they were forced to go into detail about these matters. A few people have the ego strength to explore such areas and come out the better for it. With borderline, let alone psychotic patients, the fragility is usually too great. I am not sure at this point how many of the PI borderlines were good candidates for exploratory therapy, since it is not easy to estimate how many of the 146 remainder were free enough of the burdens just mentioned to endure without decompensation and to integrate beneficially what emerged during the sessions. My best guess at the moment would be half of this remainder, or about a third of the traced, or perhaps a quarter, of the traced borderlines.
Dr. Stone now continues with a discussion of treatment issues relating to borderline patients.
Someone on my way down here asked if I had some thoughts about the high-functioning borderline patient. In the last few years, I've worked in my private practice with a little over half dozen, and they represent a range. Some were unworkable because they needed more than I, as an academic psychiatrist, could easily give. And then there are others who are motivated but too ill, often because of the kinds of constitutional factors that I was alluding to. Really, they're borderline in outward appearance, but they have unipolar depression or bipolar II depression. and are not very good candidates for this form of therapy. This reminds me of a neurotic level patient that I had some years ago who was tomboyish. She was extremely gifted. She was really a genius, medical student at the time, and had never experienced orgasm, never had any sexual relationship with anyone, and began to have a series of dreams having to do with fear of sexuality, the fear of offending mother, the fear of incest, the fear the semen will be like acid that will eat through you, the fear of babies, all of these different things, the fear of the vagina and the rectum being so close together that there's a dirtiness associated with sex, etc., etc. She mowed these down one after the other. There are about 12 or 13 items in all. I wrote it up in Journal of the American Academy of Psychoanalysis some years ago. And at the end of that, she has a wonderful dream, a fairy tale dream, where she goes off and she had been like a princess that was kept frozen in some lake, but then it thaws, and then the handsome prince carries her off and takes her into a magical country. It was really just very charming. And she had at that point her first sexual relationship with a fellow that she'd been going with, who was kind of patiently waiting for the day when this would happen, and began to enjoy that part of life, and subsequently made a rather good marriage, although not to him. This patient, who really would scarcely be distinguishable from a neurotic patient, the level that she's gotten up to, is also beginning to have a series of dreams, and she's beginning to make mutative changes in connection with the understanding of these dreams, both with respect to what they mean on the interpersonal plane in connection with her past figures in her life, and also on the transference plane. That represents, I think, a high-level borderline. I have focused so much on subtypes, the affective eating disorder one, the antisocial one, etc. But certainly there is also a gradation with respect to level of function. There's really none in the way of impulsivity in her life. She doesn't make suicide gestures. She's never really been inordinately angry during the time I've known her. She doesn't have any of the borderline items. I don't think one could make the diagnosis that she was a borderline when she was first admitted to the hospital and making the suicide gestures. Another patient I work with felt that she could only be gotten better through the analytic method, for which nevertheless she had no psychological mindedness or talent whatsoever. Has this dream where she says, "You're gay, though you also have a crush on me. I tell you I'm leaving therapy for good and you make a pass at me. You pull off a gold chain off my neck. Also, you kept my mail." She didn't even understand the allusion to maleness. And in one envelope was a picture of me, which you jealously hold on to in order to masturbate with. Well, you'd think that a dream like that would keep the wheels of therapy rolling for just months on end. It did nothing of the kind, meant nothing to her. She couldn't do anything with it. And saw none of the allusions, didn't catch any of the puns that she made in the dream about keeping her mail and so on and so forth. Certainly was a long ways from understanding any allusion to the projection of her own homosexual impulses onto me, which in her case related to her extreme dependency on and symbiotic closeness with the ambivalently loved mother, from whom she never effectively separated, and toward whom she always bore a kind of oscillating hostility and blind adoration. She would call the mother, "I'm falling apart, you gotta see me." And the mother said, "Look, I have my life, my own, I just can't make it. This girl's 36 now. I can't make it this weekend." She'd say, "You fucking bitch," and she would slam the phone down, okay? Half hour later, tears, "Mama, please forgive me, I didn't mean what I said." So that the ambivalence would be lived out in this oscillating hatred and love, hatred and love, and she had no time, in no one moment in time could she say, "I have a mixed attitude toward my mother." I recommended that she needed to simmer down through the use of lithium or antidepressant in order to gain some control over her hypomania, really, to speaking at lightning speed and inability to keep her mouth shut once she opened it. She refused to do that, said that I was treating her, like some basket case, and stormed out of the office, to the mutual salvation, I suppose, of both of us. What do you do? Well, it does bring up the topic of medication in the borderline domain. I think with a suicidal outpatient borderline, you best be careful. and give too little medication or none rather than to get burnt by it. It may force the patient into a state where they have to be in the hospital, and that's good because there at least you can do something positive for them in a controlled way. If they're that sick, they probably belong in one. Admittedly, the way things are currently, with the tendency toward short-term hospitalization, it's very hard to do adequate job with the chronically suicidal borderlines, but still one has to do what's best. The borderline patient who has no concomitant major affective disorder usually doesn't require medication, except perhaps for a mild anxiolytic. In my experience, somewhat more common situation of borderline with concomitant major affective disorder will tend to respond to tricyclics, or if that doesn't work, to monoamine oxidase inhibitors. There are people with cyclothymic personalities and bipolar II personalities, mild hypomanic tendencies, rather more marked depressive tendencies, who are fairly good candidates for a lithium trial and should be offered that as perhaps helping to stem the tide of their affective excess, and then you're left with a person who's more amenable to psychotherapy, including expressive if they have the knack for it. The bulimic patient, the agoraphobic, and the one given to panic disorders, I think that the tricyclics do help a great deal in patients with panic. The schizotypal patient, the one who is borderline with respect to schizophrenia, in general, they do not respond in any dramatic way to medication. There are a few who will occasionally, during a brief psychotic episode, require a neuroleptic. For the rest of the time, I can't say that I find it very useful because you're often dealing with suspicious, paranoid people. You have to be very careful in that group. Of course, many borderlines are mixed types. They have some schizotypal features and some affective features. And if the affective features are pronounced enough to warrant an antidepressant, particularly if they're having fairly severe bouts of tearfulness and depression and suicidal rumination over an extended period, or if it's a rather chronic situation, they may well respond to antidepressant medication. It's something that I think one ought not to have any doctrinaire view about. Clearly, if the patient has an indication for it, they jolly well ought to receive it. And if they don't have an indication for it, then you're entitled to go through the therapy without it. It should be individualized and tailored for the patient.
This concludes Dr. Stone's presentation. Please turn the cassette over to hear Dr. Leonard Horwitz on the integrated treatment of borderline and narcissistic disorders, group psychotherapy perspective. The program will continue in a moment with a discussion of the integrated treatment of borderline and narcissistic disorders by Dr. Leonard Horwitz, training analyst at the Topeka Institute for Psychoanalysis and formerly chief of clinical psychology at the Menninger Foundation. First, here is a message from SmithKline & French Laboratories. Serious medical complications and costly hospitalizations often are precipitated by patients' failure to follow the regimen prescribed by physicians for chronic diseases and various psychiatric disorders. In this statement from the September 1982 issue of Archives of Internal Medicine, Drs. Ron J. Anderson and Lynn M. Kirk focus on a problem of growing significance: patient compliance with suggested medical regimens.
Escalith CR, brand of lithium carbonate 450 milligram controlled release tablets, are designed to provide the efficacy, convenience, and comfort of BID administration, an important factor in increased patient compliance and successful treatment and prophylaxis of manic depressive illness. Escalith CR, 450 milligram controlled release tablets, when administered every 12 hours, gradually disintegrate, slowly releasing lithium without the initial rapid surge in blood levels seen with immediate release formulations. Escalith CR, 450 milligram controlled release tablets, offer physicians the option of twice-a-day dosing for optimum patient convenience, comfort, and compliance.
Lithium should generally not be given to patients with significant renal or cardiovascular disease, severe debilitation, dehydration, or sodium depletion, or to patients receiving diuretics. Lithium may cause fetal harm when administered to a pregnant woman and is not recommended in children under 12. Lithium toxicity is closely related to serum lithium levels and can occur at doses close to therapeutic levels. Facilities for prompt and accurate serum lithium determination should be available before treatment is begun. Patients should be cautioned about activities requiring alertness. Before prescribing Escalith CR, please consult the accompanying complete prescribing information, including warnings, precautions, and adverse reactions. And now, Dr. Horwitz.
What I'm going to talk about are 4 types of character problems usually associated with narcissistic and borderline patients that I think are specific indications for group psychotherapy. Demandingness, egocentrism, social isolation, and deviancy. We've learned a great deal about demandingness from Heinz Kohut and his contribution regarding the so-called mirroring transference, the need for a mirroring self-object as either overt or hidden, and that not all narcissistic characters are clearly demanding people. They may have that kind of narcissistic wish well concealed, and one of the problems he set for himself in his therapeutic method was to help the patient uncover the narcissistic demandingness. These people suffer from a pathological and insatiable need for affirmation, for validation. They need a bolstering of self-esteem, need incessant flattery, praise, recognition. There's a sense of badness, a sense of inadequacy, some kind of defect. A very apt phrase, and also the title of a book by Ballant, is The Basic Fault. And The Basic Fault captures very nicely the kind of pathology that we're talking about. It has a geological connotation of some kind of crack and some kind of crevice. Has a connotation also of the person being at fault. And I think both of those descriptions capture something about this type of person. And of course, the sense of deprivation that leads to a sense of entitlement and a feeling that because you suffered from early deprivation, you're entitled to some special treatment. Now, why is a group particularly indicated for this type of character trait? The group highlights a sense of neediness. It highlights the person's greed, the person's envy, the person's need for some response. And the way in which it highlights this is naturally the presence of others and the concern that you might lose out in the competition. What is competed for in a group are mainly 2 types of things. One is the time of the group, and the other are the responses that you hope to get from the others in the group. What are some of the common patterns in a deprived group? Now here I'm making a slight shift from talking about deprived patients to deprived groups. It's my belief that the best way of trying to work with such patients and such problems is to find the common thread that goes on in the group, the common neediness of the group, and work with the individuals through a group theme. What happens when a group becomes deprived? Typically you see that when there's some kind of interruption in the group, when the therapist takes a vacation. When new members are being brought in, that's another occasion for a great sense of threat to the members. One pattern that I have found very interesting that's demonstrated during this phase of the group is the group begins unconsciously almost to begin taking turns. And the worst manifestation of this is for the group to assign one member per session and say, in effect, to that member, you will have the entire session for yourself. then a rotational system is set in, and sometimes that's a little bit hard to pick up, but I think is important to notice and important for the therapist to try to interpret and deal with. But it's an effort on the part of the group to be sure that everybody gets their turn, and also it's a manifestation of a defense against one's wanting to take all of the time. Another way a group manifests their sense of neediness is to fail to respond to each other. And that has a special meaning too. If you notice that somebody brings a problem into the group and everybody sits on their hands and has nothing to say, no response to make, and is in effect freezing the other person out, they're making a number of different communications. One is, I feel so deprived I have nothing to give. And the other is a kind of pressure on the therapist to start making the responses. Even though I believe that the therapist should serve as a catalyst in the group, I do not believe that he should be filling the roles that rightly belong to the other members, and I think it's important for the therapist to point out to the group that they're not really doing their job. Then something which is a reverse of what I have been describing is the tendency to monopolize. Very frequently, a patient who is feeling deprived will take an entire session, not because the group is pushing him into it, although of course the group has to collude to a certain extent, but because he is feeling so deprived and feeling that he needs this kind of extra time. What I've been trying to point out with regard to demandingness is that the group, in contrast to an individual therapy, really highlights and brings to the forefront the patient's demanding tendencies. And at the same time, the group provides a medium for pressuring the patient into giving up this very self-centered attitude, and in effect is a civilizing type of social setting for the patient. The second characteristic, which is egocentrism, and of course is really a corollary of demandingness, and the aspect of egocentrism that I want to focus on in particular is the difficulty in giving. Winnicott, the British object relations theorist, has used Melanie Klein's idea of depressive anxiety to explain an important basis for this difficulty. What he describes is the problem that the individual has in his early development in being able to integrate loving and hating, in being able to integrate the aggression with his love in one person. This is commonly referred to as the basis for splitting, and the difficulty that the individual has in overcoming his tendency to split provides the basis for the problem in being able to think about another person in terms of himself rather than in terms of one's own needs. As long as the splitting phenomenon occurs, and you tend to over-idealize people or devalue people and have the inability to bring both of these characteristics together, it becomes difficult to see an individual in anything other than his being some ideal figure who can provide something for you, or his being a maligned figure whom you want to avoid or attack, but it becomes difficult to see the person as a whole person. Many people who come into a group, and I'm afraid many therapists who think about groups, believe that the kind of treatment or the occasions for getting treatment occur when the person is talking, when he's bringing out his problems, when he's talking about some given issue. That is a fallacy. I think that group psychotherapy works not only by self-disclosing, but it also works by participating and interacting. And it's just as important to invest in others, think about others' problems in a group as it is to think about your own. The advantage of the group is that the group will often begin to confront a patient who is so self-preoccupied. It's a real sign of progress when you begin to see a patient who initially was unable to do anything but think about their own needs, about their sense of deprivation, and pay little attention to others in the group, to begin interacting and begin showing some real concern. Let me move on now to third characteristic, and this has to do with social isolation, often referred to as schizoid withdrawal, social neurosis. These people are generally loners. There are multiple causes, of course, for their remaining isolated. It might be on some phobic basis, might be due to paranoia, might be due to feelings of inadequacy. A group situation helps this kind of condition in a number of different ways, I believe. One is the opportunity for these people to see others emote, which often is a new experience for some particularly isolated people who have not been able to form relationships of the kind that would really permit them to share somebody else's or be able to observe somebody else's emotional reactions. These patients are often referred to as emotional illiterates. They're people who really don't understand the meaning of affects and fail to experience it themselves. The fourth characteristic is deviancy. Deviancy is behavior that's strange, abrasive, elicits ridicule. It's generally associated with some weakened reality testing, insensitivity to others, out of touch with the impact that you make on other people. The egocentric needs of the person override what the environmental needs might be. Here I'd like to refer to the big Ks, Kernberg and Kohut, as a way of trying to put that characteristic into context. Kohut, coming at this problem from his self-theory, talks about the fragmented self resulting in drives showing themselves as fragmentation products, so that anger, sexuality, narcissistic needs begin to push through. And instead of these drives, these motives, being embedded in a relationship matrix, they are really operating in a purely narcissistic way. That is his idea of how deviant, self-centered behavior will show itself. Kernberg, on the other hand, addresses the same problem from the point of view of structural ego defects, and he emphasizes primary process intrusions and non-specific ego weakness like impulsiveness and low anxiety tolerance. In a somewhat similar way, the egocentrism and the egocentric drives break through, and they show up in various kinds of highly egocentric, erratic behavior. One example is strange dress. Patient used to come to the group with sneakers that didn't match, and there are just a whole gamut of evidences of this kind of deviant behavior that is often abrasive and of which the patient is minimally aware. A group is an ideal place for such manifestations to be seen, because it's not just dress, but it's often erratic, eccentric behavior that comes out that the group is able to observe and deal with. I think that groups have the capacity to have a strong civilizing and socializing influence on its members. Once the member begins to feel accepted and can begin to feel some kind of pressure from his peers, those kinds of deviant behaviors will tend to be modified. A group also provides an opportunity for identification with other patients and with the therapist in providing a model of altruism, a model of concern, model of paying attention to others. And I think that's also a valuable mechanism in a group. The egocentric patient has great difficulty in giving. Part of the group task is not only to self-disclose, but also to respond to others. The socially isolated patient, who usually has frozen affectivity, who is usually an emotional illiterate, the group provides a support to the patient to risk sharing affect. And finally, the deviant patient experiences acceptance in the group, then can begin to experience some of the confrontation concerning his socially deviant and abrasive behavior. One of the biggest errors that I have observed in people forming groups and taking patients into a group, and this applies not only to borderline narcissistic but to individuals in general, is that they do not have a long enough preparatory series of interviews with the patient. I like to see a prospective group psychotherapy patient at least 4 or 5 times before I will take him into the group. And this applies even if the patient has been worked up by somebody else who has made the recommendation for a group. By and large, people come seeking help and expecting a recommendation for some kind of individual work, and admitting them to your group the very next session does not give the person an opportunity really to deal with his feelings that may be coming up within that session but often come up afterwards about what it's going to feel like going into a group. I've already mentioned a number of factors that ought to be evaluated in addition to the intensity of some of these narcissistic and borderline features. Certainly his motivation for treatment is a very important factor. What kinds of fantasies he has about the group. Is it going to be a confrontational group? Is he going to develop anxiety about being attacked? Try to evaluate as much as possible the dropout potential of the patient and avoid as much as possible taking a person who is likely to be dropping out quickly, partly to protect the patient from the damaging experience of failing, but also to protect my group against the narcissistic injury of somebody coming into the group and not working out, which the group always experiences as a failure. Another reason for a prolonged series of interviews with the patient is to develop some kind of working relationship, some kind of alliance, if you will, some feelings of trust, some feelings of being understood before you have him go into the group. Entering into the group is always an anxiety-inducing experience. You don't feel terribly supported, and it's good to have the therapist whom you can rely on in the first several sessions when things are most anxious for the patient. One of the difficulties that you also ought to bear in mind is that when you bring a patient into a group after having seen him for, say, a half a dozen sessions, there's always a great sense of loss. The patient has had this individual therapist, even if it's been just for a few sessions, but he's felt a certain kind of specialness, and suddenly he's thrust into a large group and he's lost his special position with the therapist. One way I have of trying to keep that from becoming too intense is to be sure in every one of my individual sessions that I bring the group into the individual session and encourage the patient, if only to say, have you had any more thoughts about going into the group? Another thing that's very important is preparing the group for the entry of the new member, and I like to take several sessions to deal with it in every session and listen for material which will reflect upon their feelings of the new baby coming into the family. A very common response on the part of a group when the new person comes in is that new person is your new favorite. The parallels to babies coming into the family is really the best model one could use. Now I want to say a few words about combined treatment. I think that the majority of these patients, the patients that fit into the narcissistic and borderline category, do best when they have both a group and an individual therapist. In the first place, a group is not initially as supportive as an individual relationship is. At the beginning, there is a great deal of anxiety about entry into a group. There are a lot of different kinds of people that you have to get to know, and there are lots of feelings about these strangers which the person in individual therapy doesn't have to confront as much. He only has to confront the strangeness of one person. He also has to confront in the initial stages the inevitable resentment. No matter what the therapist does, he's going to have to face a certain amount of resentment which is directed towards him as the newcomer. Now, what role does the individual relationship serve to the patient who's going into a group? We were talking about people who are feeling very deprived, who have a sense of entitlement, who are very easily injured. In the first place, the individual psychotherapy relationship provides gratification of needs that you cannot easily provide in a group situation. You have the therapist all for yourself, particularly with narcissistic people who want to feel special. This certainly will give them an opportunity to get that kind of experience. In the second place, the individual psychotherapy helps to dilute the group transference, mainly by providing a vehicle for sort of switching back and forth from the group therapist to the individual therapist as the one in whom one makes some primary investments. So there may be times when the patient is doing most of his work in the individual therapy and the group therapy serves as a supportive function, and vice versa. That actually brings on many different kinds of problems, and you can see you're really setting up a very fertile field for splitting, and that's something that has to be borne in mind. And when you do have a patient who is both an individual and group, watch for that and also keep communication going between individual therapist and group therapist. I think it's inevitable in a group situation that a person is going to go through a certain amount of narcissistic injury. I mean, some comment that somebody will make that might even go unnoticed by therapist or group as being offensive, or turning the attention from that individual before he felt he was ready to let go of the floor. These kinds of things provide a narcissistic hurt, and I think it becomes important with most of these patients to provide them with an opportunity to deal with the hurt in the individual situation. One of the disadvantages of that is that it also provides the patient with an opportunity to act out, in a sense, by taking all the group problems into the individual situation and not dealing with them, and that's another byproduct. I've mentioned all of the kinds of negative possibilities when you have an individual and group combined treatment. There's certainly the tendency towards splitting. There's the need for communication between the therapists. But at the same time, I think with many narcissistic patients in particular, it's impossible to keep them in the group. The demands might be so great and the pressure on the group might be so intensive that it would be very difficult to keep them in the group without having some combined individual therapy.
This concludes the first in a series on borderline and narcissistic disorders, recorded live and on location at the 8th Annual Psychiatry Conference of the Menninger Foundation. SmithKline & French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline & French Laboratories.